Continuing with the diseases of the oral cavity, one more of the condition which we commonly see is the halidosis or bad smell in the breath, and many people will be complaining of this issue, and majority of those conditions are due to unhygienic conditions of the oral cavity, and in that condition it's not a question of any medical treatment. The hygiene and practice have to be improved. Now, in other conditions, the pathology could be Sanipata, Anekabho, Durganda Asrava Pichilo, Akasmatam Lana, Samshuna Rujo Vishamapakano, the post of Prabhaka, that bad smell produced is considered as one of the conditions which is produced due to Chidosha. The other possibilities which can occur could be patients who consume the sulfur containing substances, and because of that, the volatile sulfur compounds present in the air breathed out could be one of the reasons, or the sulfur compounds also could be produced due to presence of H. pylori in the gastrointestinal tract. That could be one of the reasons. Then hypersalivation. Patients may have a pathology where the saliva could be reduced. Patients with upper respiratory infections also may have a foul smell breath as such. Liver diseases also are one of the sources or one of the causes for the foul smell in the breath. Certain specific food like garlic, fish, etc. also can produce a foul smell in the breath. So, in these conditions, before we go for any plan of the management, the important is you have to rule out the other conditions, like the dietary causes have to be taken care of. Patient has to be advised to take more of green vegetables, maybe raw vegetables are better than the other, and the oral hygiene has to be maintained properly. And even after this, if there is still a pathology like a salivation is lesser, or there could be abnormality of the digestion process, in that condition I would prefer Agnichandivati, Hingvasakachurna to be given internally, and Trifala Kwasa Gandusha is one of the other remedy which can be given as a broad spectrum course of treatment for the halitosis, foul smell breath conditions, and majority of the conditions would have satisfactory improvement. But the most important cause would be to identify the reason for it. Then, as far as the oral cavity is concerned, tongue is concerned, there is a school of thought which says that by looking at the tongue, the whole systemic disorder can be identified. That tongue as a diagnostic tool is used in certain branches, not so mainstream, certain branches of the medicine, where they say that the representation of these structures like intestines, pancreas, stomach and heart, also the lungs and liver, spleen are represented in the tongue area. By looking at the tongue, you can diagnose a pathology. Of course, I am not sure about that. I don't have any experience of that, but this is one of the issues. And patients, of course, there is that school of thought also says that by looking at the tongue, you can diagnose certain, a good number of systemic disorders. Some of these conditions may be possible, like a patient with the sensitive colon, there could be a hemorrhagic spot over the area, and toxins in the colon, there could be a coating over the posterior surface. Toxins in the whole of the GI tract, there could be again a bigger patch in the area. That coating is considered to toxin. Bronchitis may present with the coating over the anterior surface of the tongue. Unabsorbed nutrients, patients who have a abnormality of the malabsorption, the tongue tends to be bald in the anterior half, and patients who have lungs abnormality, the whole tongue becomes somewhat reddish and fragile. The surface would be quite reddish as such, and these are certain of the conditions, and that kind of a diagnosis is considered to be one of the advanced branch, certain specialized branch as such, but I don't have any experience of that. This is just to sensitize, like that kind of a system does exist. Anyway, that's about the oral cavity disorder. The next part we go into would be the esophagus. Among the esophageal disorder, the very common, the frequently seen condition is what we call as a gastroesophageal reflux disorder or GERD. The gastroesophageal reflux basic phenomena is in the normal conditions, the stomach and the esophagus, gastroesophageal junction, acts as a competent valve which doesn't allow the substances from the stomach to flow through into the esophagus even when the pressure in the stomach is increased. Unless in the act of vomiting, there is a reflex coordination of the muscles in such a way that there could be this reflex as such, but in the normal conditions there would not be a backflow. And if at all there is a backflow due to any reasons, we will come to that reasons, like if there is a backflow of the contents of the stomach into the esophagus, because the esophagus mucosa is not accustomed to the low pH of the stomach content. Stomach content would have acid and hence the pH will be low. Esophagus doesn't have that resistance. Esophageal mucosa doesn't have that resistance to the acid as such, and hence the mucosa becomes inflamed, and that produces what we call as a gastroesophageal reflux disorder. Now, a gastroesophageal reflux disorder, a continuous contact with the acid in the esophagus, can result in changes in the mucosa, which can even result in either ulcers or in metaplasia, and it can result in dysplasia. Even it is considered to be one of the causes of adenocarcinoma. There is a chain of sequence of events like esophageal reflux disorder can lead to the carcinoma. Now, a typical clinical symptom of gastroesophageal reflux is a patient would have heartburn, burning in the substernal area, or dyspepsia, the most common symptoms. And typically that heartburn symptoms are more after food, and particularly if the patient sleeps or lies down after consumption of food, the more the symptoms would be. And in the erect posture, the symptom could be slightly lesser. And even at times it could be a pain, chest pain, which is in the substernal area, and many a times it can produce a confusion with the coronary arterial disorder. A good number of GERD patients, they are clinically suspected to be having a coronary pathology and then investigated in that direction, and if a negative investigation comes in, like negative findings come in when you go for the or when you try for ruling out coronary disease, then you may come to a diagnosis of esophagitis. So that's called as peptic esophagitis or reflux disorder. In addition to that, the other symptoms which could occur could be excess of salivation, water rash. And patients even may have a regurgitation symptom, like the food which was consumed again coming back to the oral cavity could be the symptoms in some of the patients. And the patient may have even nausea, bloating, fullness, dysphagia, even occasionally dysphagia, or odynophagy is a bad smell during the swallowing, as such cough or hoarseness, wheezing, or hematemesis also can occur rarely in case of the reflux esophagitis. Causes for the esophagitis are either there could be a abnormality of the lower esophageal sphincter. Very commonly it occurs due to lower esophageal sphincter relaxation, which is often related to the obesity. Patients who have obesity, because of the deposition of the fat in that muscle, the sphincter muscles, the muscles become relaxed, and hence the competency, the pressure, this capacity to hold the pressure would be lesser. Or it also can result in the lower esophageal sphincter pressure. Either it could be neurological pathologies also. Patients who have undergone some chest surgery earlier for any of the conditions, they tend to have some neurological lesions, and hence the sphincter tone can be reduced and it can become a relaxed asset, and it can result in the flow back. Sliding hiatus hernia is another cause. Now, as far as sliding hiatus hernia is concerned, it is considered to be a cause for gastroesophageal reflux, as well as it could be a consequence of gastroesophageal reflux even. A patient who has a gastroesophageal reflux can result in a fibrosis, and that results in a short esophagus which may pull up the stomach mucosa into the chest area, and it can result in sliding hiatal hernia. Or the other way, a patient who had a sliding hiatal hernia due to other reasons also is more prone to have the gastroesophageal reflux condition. Then another cause can be due to improper motility of the stomach. If the stomach motility is reduced and the food remains in the stomach for a longer duration, Now, food can remain in the stomach for a longer duration due to many reasons. One, it could be due to the reduced motility, altered motility, due to abnormality of the autonomic nervous system. See, parasympathetic and sympathetic system balance would regulate that gastric emptying period, and particularly the parasympathetic helps in passage of the contents from the stomach into the distal area, or facilitates that, whereas the adrenergic system, it reduces the motility. Now, if that balance is lost and if there is a increased adrenergic activity, which often occurs due to stress, the gastric emptying period could be prolonged, and that can be a cause for esophageal reflux disorder. Or it also can result due to the distensibility of the gastroesophageal junction. If the, or maybe in the stomach, the gastroduodenal junction becomes somewhat rigid. In both these conditions, if this gastroesophageal junction becomes more wider, and or it could be due to a gastric emptying being delayed, or a person who tends to eat frequently, doesn't keep the stomach empty, also is more prone to develop the esophageal reflux disorder. So those who tend to eat more frequently, consume the food quite frequently at short intervals, they are more prone to develop that. Then obesity, as I told you, it can reduce the tone of the muscles, and it can be a cause for the esophageal reflux disorder. And the typical esophageal symptoms are, as I told you, it's a heartburn, regurgitation, dysphagia, and it also can produce atypical symptoms like coughing, wheezing, hoarseness or sore throat. At times it could be middle ear infections also, or non-cardiac chest pain, and erosion of the dental manifestations also can occur. And it's one of the very common disorder now, and every year the number is increasing throughout the globe, in every country. The trend of gastroesophageal reflux disorder is increasing. It is supposed to be due to the lifestyle factors. Sedentary lifestyle also is one of the causes for that, and almost in every country throughout the globe, the number is increasing, and particularly in East Asia, India and other surrounding areas, the number is huge, increasing. The incidence is quite huge as such. So gastroesophageal reflux disorders now are graded into 4 grades depending upon the severity seen on the esophagoscope, and this classification is quite important to predict about the outcome and whether we can treat that condition or not. The grade A is where the extent of the inflammation seen in the endoscopy is just around 5 millimeters, and the mucosa is not really affected. There is no scar marks as such. When there is a longitudinal scar or wound and the extent is more than 5 mm, then it's considered as grade B. Grade C is there is a scar mark, and the mark is seen as a horizontal rupture area, a band-like area where there is a inflammatory changes. That's grade C. And grade D is when the extent is more than 10 centimeters and there is a huge area of patching. As you see in the esophagoscope, the lower grade A, that grade A is where you may see the inflammation within 5 centimeters. There could be just maybe some vertical areas of the erosion, the different types of this erosion, and which are not more than 5 millimeters longer, and usually the history is short duration, and often it's linked to food, and most of the time self-limiting. Patient may have the symptoms for a few days and then it may subside. When you do the esophagoscopy, you may see these erosions, and they are quite frequently seen. Now almost every third gastroscopy done among the 5, you will find the maybe 1 in 3 would be having this kind of mild esophageal reflux, and many times these can be just neglected as casual because of our present situation, and most of the times it is due to the food habits, and these can be corrected by the simple food habit modifications like reducing the frequency of the food intake, quality of the food. Spicy food has to be reduced, and the patient has to be advised to take at least half an to 1 hour gap between the sleep and the food intake. By this, many of these symptoms can be managed, and this is exactly what you see in case of the Chaya Lakshanas. Disyakriya Prakopat Kostathoda Sancharana Amlika Pipasa Paridaha Annadvesha Hridaya Klesha. These are the symptoms of the Vruddhi stage of doshas, which are self-limiting. That's all the important thing. There may not be a need for treatment in that condition, and a modification of the lifestyle could be the treatment there. The grade B is where you will find a extent which is beyond 5 centimeters and larger than 5 centimeters, and there could be cicatrical changes or scar mark seen, constriction seen, either horizontal as you see over here, or it could be occasionally this vertical or horizontal also, both these, and the symptoms tend to become constant, and they can persist even irrespective of the quality of the food. Many a times the patient may say that they would have the symptoms even when they consume food like milk. The symptoms may persist. Such conditions, they are the advanced stages, which we consider as either Amadirna or the Vidagdhajirna. तत्र आमे गुरुता उत्क्लेदः शोधः गण्डाक्षिकुटकः उद्गारश्च यथा भुक्तम् अविदग्ध प्रविद्यते. That यथा भुक्तम् उद्गारः, the patient having the same smell and taste of the food during the this irritation, which persists for a longer duration. See, first or two, the regurgitation, maybe irritation occurring within a few hours, 1 hour after the food consumption, may have the same smell. It's normal, but when it is persisting for a longer duration, that suggests about the reflux. Or it also can result in the sadhuma uggara. A uggara with burning sensation also is characteristic feature of the grade B or second type of esophagitis, which is commonly seen. And again, the frequency of this also is quite high. A large number of patients would present with these symptoms. And in these conditions, my prescription would be Surshekara, Kamakula, Godanti and Avipatikara, along with the lifestyle suggestions which are common. Then in the grade C, the erosions are extending over the mucosal folds, and the mucosal folds, they become completely cicatrized, and maybe the whole of the circumference or maybe around 3/4 of the circumference are involved, and the shape is quite altered. The esophagoscopy findings are very classical, and in these conditions the patient would have a intolerance to the food. Weight loss also occur, and the patients would have a severe impaired appetite, and this is typically, I would consider as the ajirna with the advanced ajirna, where the symptoms like कटु अजीर्ण विदाहि अम्लक्षाराद्यैः पित्तं मुल्बणम् आप्लावयति हन्ति अनलं जलं च तप्तं इव अनलं. There would be burning sensation throughout, and the whole digestive capacity is affected. सजीर्णं नीलपीताभं पीताभस्सार्यते ध्रुवं पूति अम्लोद्गारः, that हृत्कण्ठदाः अरुचिः तृडर्दितः. In these conditions, the outcome would be poor. You will have to explain the patient about the outcome, because and the risks of going into malignancy also are higher later on. And in such conditions, my prescription would be Arogyavardhini or Agnithundi, depending upon the clinical presentation. Surshekara and Godanti would be the usual prescription. There would be somewhat satisfactory improvement. Then grade D is the advanced stage, where there could be severe erosions confluent, which are seeming to be one merging with the other, and the whole circumference is involved, and there is severe erosions to occur, or even there could be some hypertrophy features. The surface area of mucosa may be seen, and these are conditions which are having extremely poor condition. Symptom will be almost the same, but more severe symptoms would occur. So esophagoscopy is one of the important benchmark method of grading and predicting the prognosis. Extremely poor prognosis, and my treatment would be Arogyavardhini, Kamakula, the same, plus Virechana with Sukumar Krita Snehapana. But the risk of malignancy is higher, but some of the patients would show some satisfactory response. But the risks of malignancy and a recurrence rate also is quite high in such conditions. So that's about the GRD. Hiatus hernia is the other condition which, as I told you, either could be a consequence of esophageal reflux disorder or at times it would be congenital. Hiatus hernia is classified into mainly two categories: sliding hiatus hernia and rolling hiatus hernia. Sliding hiatus hernia is when the gastric mucosa is seen in the chest area. So when you do the esophagoscopy, the gastroesophageal junction becomes lax and the gastric mucosa is pulled up, which is due to the short esophagus. Short esophagus could be congenital or it could be acquired as a result of esophagitis. Or the rolling hiatus hernia is due to a gap in the diaphragm surface. The greater curvature of the stomach fundus area would be projecting into the thorax and it will be seen in the thoracic area. That's the rolling hiatus hernia. From the clinical point of view, sliding hiatus hernia is more frequent, more important than the rolling hiatus hernia. Rarely we see the rolling hiatus hernia conditions. That's the consequence of the esophagitis. And once the sliding hiatus hernia is considered, again the treatment protocol would be the same. When I say sliding hiatus hernia, my treatment protocol would be the same as we discussed about the esophagitis. And the only thing is that prognosis is poor. Surgical treatment of repair of the hiatus hernia, sliding hiatus hernia, is one of the options, but most of the times the surgical repair would be producing more complications. Whereas the rolling hiatus hernia, which is often a consequence of some previous abdominal surgery and hence the diaphragm has become somewhat incompetent, a surgery is a must. But luckily, incidence of rolling hiatus hernia is very low. Typically, in a rolling hiatus hernia, the clinical symptoms would occur as intermittent dysphagia. The dysphagia is when this bag, like the component of the stomach which is present in the thorax, is filled up with the food. The patient would have dysphagia due to the pressure on the esophagus. Whereas once this becomes emptied during the normal movements, the patient may have a normal passage of the food. So intermittent dysphagia is the condition, and the confirmation of the diagnosis is done either by barium meal X-ray. In the barium meal X-ray with the head and direct lower position or Trendelenburg position, you can see the barium reaching up to the thoracic area. Shadow can be confirmed, or maybe the esophagoscopy also confirms the same. And the treatment is essentially surgical, but incidence is very low. Whereas sliding hiatus hernia, which is a consequence of esophageal reflux disorder, or maybe it also results in the esophageal reflux disorder, we can manage the patients with the medical treatment almost on the same lines as we have discussed in the esophagitis condition. One more of the complication of GERD is the Barrett's esophagitis. Barrett's esophagitis is a specific name given to a situation where there will be dysplasia. The mucosa is, there will be a huge ulcer, big ulcer, and the mucosa is altered. The pattern of the mucosa is altered. It looks like shiny, dull looking, like the normal shining appearance of the mucosa is altered. And the extent could be of any degrees. It could be limited to some areas, may be extensive. At times it may even result in a hypertrophy, which is considered as the malignancy. Now, when you look at the esophagus conditions, the typical appearance would be like when in a Barrett's initial stages, the layer would be replaced by, the mucosal layer would be replaced by squamous epithelium seen under the microscope, and corresponding appearance seen in the esophagoscope. When there is a dysplasia with the Barrett's esophagus, the appearance seen would be like this, and whereas microscopic appearance would show a tendency of dysplasia, abnormal growth as such. At the advanced last stage, it could be a malignant condition where there could be bulging, which can show the adenocarcinoma, and hence every patient of Barrett's esophagus condition, a biopsy is needed, and the prognosis is depending upon the findings which you see under the biopsy. If there is a dysplasia, that beyond that dysplasia stage, virtually there is no question of any medical treatment. The treatment has to be considered as a precancerous condition, and the treatment has to be from the point of view of malignancy. So the treatment protocol has to be complicated, and outcome also will be depending upon the malignancy. Then another variation of the esophagitis is what we call as the eosinophilic esophagitis. Eosinophilic esophagitis is characterized by a clinical presentation of the same, where usually more in children with vomiting, dysphagia, abdominal pain. And when you look at the mucosa in the esophagoscope, you will be seeing these areas of atrophic with some sort of proliferation. The surface looks like having some uniform marble appearance, like that's what we call as the lamellar appearance, as if some marble or some stone pieces are aligned together. That kind of an appearance is seen in case of a eosinophilic esophagitis, and most of the times it is due to immunological origin. Often could be related to the other systemic disorder, or at times it could be due to some sensitivity to the food material. The blood picture occasionally may show eosinophilia, though it's a eosinophilic esophagitis, as we say. Not necessary that every patient would have a raised eosinophilic count, but a good number of patients may have that. And in that condition, the treatment, my prescription would be Agnitundi, Sutushekara, Bhurimbali or Drakshasava, depending upon the clinical presentation as such. And the results are quite good. Eosinophilic esophagitis can be better treated with our treatment, whereas in the contemporary medicine treatment, virtually it's a very, the poor outcome would be poor. Then another rare condition is infectious esophagitis. Infectious esophagitis produced due to severe infective pathology. Among them, from the clinical point of view, important is Candida. Candida is a fungal sort of pathology which is often seen in patients who have immunocompromised conditions like HIV. Among the HIV patients, this is a very frequent event, whereas even patients who are undergoing radiation or chemotherapy, these complications can occur. Other viral induced pathology like cytomegalovirus or HS virus also can produce this esophagitis, which are the poor prognosis. From the gastroscopy point of view, when you do the gastroscopy, these findings are important and these suggest of a poor prognosis. And the protocol of the treatment would be depending upon the underlying pathology as such. That's one of the issues. From our clinical management point of view, suppose a patient has a candida virus, candida fungus, the systemic pathology has to be confirmed and then that has to be treated. Even in other viral pathologies also, there could be immunocompromised conditions which need to be treated. Another variation which is often seen is corrosive esophagitis. Corrosive esophagitis is due to consumption of the corrosive substances like acid-containing substances, or these days it also could occur due to certain food substances, food habits. Consumption of very severe spicy food substances also produces corrosion. And often the corrosion is also seen in accidental injuries where patient may consume some acidic or these alkaline substances orally, which produces a burning damage to the mucosa. In these conditions, if the patient comes to you immediately, then instead of gastroscopy, the better is to dilute that irritant substance with water so that the effect will be lesser. And as a rule, the gastroscopy should not be done within 48 hours of such corrosion history, because that the surface is fragile. So when you do it after 48 hours at the early stage, that's around 2 to 3 days after the corrosion, a mild corrosion would be seen as some area of inflammation which is almost indistinguishable from esophagitis as such. Whereas in advanced stage there could be a severe necrosis and the whole esophageal mucosa may show a permanent changes as such. And theoretically it's graded into four grades, like grade 1 where there will be edema and hyperemia, the mild conditions, and superficial localized ulcerations, or circumferential and deep ulcerations. These 3 stages can be managed medically, where we usually prescribe Sutushekara Kamaduga as such. Whereas when the next stage, 3A, 3B, and where there will be extensive necrosis or even perforation, they are rare conditions of course, but when they occur, virtually it cannot be treated medically. Suppose a patient comes in that advanced stages, one of the important part of the initial management will be you have to maintain the nourishment of the patient by putting in a Rayleigh tube or maybe a gastrostomy tube as per the necessity. That's the one of the condition. Next of the condition related to the esophagus is esophageal stricture or a situation where the esophagus becomes narrowed and the food cannot pass through. And often this could be a complication of the erosion earlier, or it could also be a complication of the esophagitis like conditions. Stricture could occur as a complication of the GERD, or a stricture also can occur due to some extra esophageal causes. And one of them would be Mallory. I will come to that Mallory syndrome next part. Now, typically the clinical presentation of a esophageal stricture will be dysphagia, which is more for solid food than the liquid, and the liquid could be swallowed, and the patient may even have weight loss. The stricture could occur at any area of the esophagus. If it is due to corrosive substances consumed, the stricture would be more prominent in the proximal portions at the oral pharyngoesophageal junction, and in the first one half of the esophagus, the incidence, the severity will be more. Whereas in the esophagitis, like reflux esophagitis produces a stricture, the situation would be, the stricture would be more in the lower portion of the esophagus or distal portion of the esophagus. And there would be always a proximal dilatation seen. So when you do the barium swallow X-ray, the barium swallow would be seen to be having a restriction, stricture there, and the proximal dilatation, the dilatation of the portion of the esophagus proximal to the area of the stricture, suggests about the severity and the chronicity. Longer the duration, the dilatation would be more, and more the obstruction, the proximal dilatation would be more. So in all cases of such barium swallow X-ray, we give more importance to this diameter of the proximal loop to predict the outcome as such. That's the condition. Of course, in that condition, virtually there is no question of medical treatment. It has to be surgical treatment so that the patient would have a normal consumption of the food to maintain the nourishment. Mallory syndrome is an acute rupture of the esophagus, often related to the alcoholism. Patients who have an acute alcoholism, and when they vomit out after consumption of alcohol, the coordination of the muscles of vomiting would not be proper. Ideally, when a vomiting reflex occurs, the sphincters of the gastroesophageal junction and the pharyngoesophageal junction in the proximal area, they should open simultaneously so that the contents of the stomach would be pushed into the esophagus and vomited out. And at the same time, the abdominal muscles will contract and abdominal pressure will increase. Whereas esophageal pressure should be reduced. The gradient between the abdominal pressure and the esophagus is the factor which helps in the movement of the food from the stomach to, or movements of the content of the stomach into the esophagus and vomiting out. But in the patients who have some either alcoholism or any other, maybe at times it could be other causes also, this coordination is lost, and pharyngoesophageal junction, instead of getting dilated, it gets constricted. Then the pressure in the esophagus would be enormously high, and that pressure in the esophagus may produce a rupture, and that condition is called as Mallory syndrome. This acute rupture would occur. In this condition, the most serious issue would be, because the pressure would be more and the contents of the stomach will be reaching to the esophagus, there could be a leakage of the contents into the mediastinum, and the mediastinitis would be presented, and that becomes critical. Mediastinitis is the one of the critical issue, and in such conditions where the patient would have a vomiting with the severe complications of the chest pain, and many times the patient may have even vomiting of the food, blood mixed vomiting also. According to Sushruta, it is considered as asadhya. Kshinasya upadrave yuktaha sasra puyam sachandrikam chhardim prasaktam chhatsat chhardi is asadhya. In the present situation, the main symptoms are acute pain, and majority of the conditions would be having a acute surgical emergency like mediastinitis, which becomes quite critical. Whether the patient requires an immediate surgical attention or whether he can be managed with conservatively would be depending upon how much of the substance has leaked into the mediastinum, severity of the mediastinitis is acting. If the mediastinitis is severe, it has to be drained immediately, so a thoracic surgery is necessary. If otherwise, then you maintain the patient on a feeding tube till so that there will be no more leakage, and the diet and rest would be enough in such conditions. Then the other conditions related to esophagus are motility disorders. the abnormality of the movement of the esophagus, movement of the food substance in the esophagus. And these could be again categorized as achalasia, where there is a severe spasm of the circular muscles as such, or it could be the spastic conditions or non-specific motility disorders or secondary esophageal motility disorders due to systemic disorder like scleroderma, diabetes mellitus, alcohol consumption, or psychiatric disorders as such. So that's about the categorization. From the clinical point of view, achalasia is the most important thing. Achalasia is a condition where there could be a hypertrophy of the circular muscles of the esophagus, and there would be a thickening. And it again could be graded as per our esophagoscopy findings, and the variations could be like either it could be a stenosing esophagogastric junction where the gastroesophageal junction could be narrowed, or there could be a wrapping of the esophagogastric junction, a fold of the mucosa over the area, or abnormal contraction of the esophageal body. The whole of the body of the esophagus may be contracted, another variation as such, or there could be mucosal thickening as a consequence of the hypertrophy, or even there could be proximal portion of the esophagus become dilated, or there could be residual food elements, food substances present in these. These could be the findings in esophagoscopy of the achalasia. More frequently what we see is the spasm, esophagogastric junction having stenosis, or the food substances present with the dilatation would be the findings which we see in case of that. Achalasia, I would consider it's a pranamrita udana, and the treatment would be snehapana with Indukanta and the Virechana would be a relatively effective treatment, and barely when it is very severe and advanced, the surgical treatment may be necessary. Surgical treatment of repair of this would be the issue. Then diffuse esophageal spasm is a rare condition which is often due to neurological conditions, psychiatric conditions. Patients who have acute stress, there could be diffuse esophageal spasm. And typically the esophageal spasm presents with the symptoms like a severe dysphagia, and the dysphagia becoming more severe for liquids than really the solids, and the dysphagia would be more when the patient attempts to swallow the food, or when there is more stress as such. It's a stress induced condition. And if the patient takes relaxants like nitrates, the patient can swallow better. The usual treatment given in the contemporary medicine is nitrates given just prior to the food so that the patient can have the food. Now, diagnosis of this is done by a typical barium swallow X-ray, where when you do the barium swallow, the whole of the esophagus show a spiral-like appearance due to the spasm. As the patient swallows the barium, these changes can be seen. And in that condition, the contemporary treatment is only the nitrates given. But from my experience point of view, a good number of patients have shown a satisfactory response with the Virechana, with the Snehana, with Vindukartakrita, Smritisagarasa, Agnitundya and Kumari Asava. The patient may show somewhat better relief than otherwise. Now, a rare condition is the Shatsky ring, another of the esophageal obstructive condition, where there is a ring-like structure produced through the spasm. It's again, the clinically present symptom would be patient have a short duration of the dysphagia. For a few days, the patient have a dysphagia, and because of that, and usually it occurs like when the patient starts food consumption of the food. Initially, few swallowing may not show the spasm, but as the patient continues to take the food, the spasm becomes more, and hence the patient would have dysphagia. And because of that, typically the patient would have a habit of consuming the food rapidly, hurried fashion. The bolus of the food initially, in the first stage swallowing, the bolus may pass through out easily, but consequently the patient may feel like he is not able to swallow the food, and often they develop the habit of drinking liquids along with the food, so that the food is forced through, and this dysphagia may be there for months or years for a short duration. Then again, it may have a spontaneous resolution, and that's when you do the esophagoscopy, you can see that spasm of the ring-like structure in the esophagus. That's a Shatsky ring, and their treatment protocol would be same as that of the spasmodic conditions. I would be treating that patient with the Smrtisagara Sagni Tundi Kumari as well. Then the next part is about the esophageal tumors, malignancies of the esophagus. Incidence of the malignancy of the esophageal tumors is quite high, and particularly in Eastern Asia, including India, the incidence is quite high. Both incidence of the cases as well as the death is quite high. And the mortality causes, well-known causes are smoking, alcohol consumption, and high cholesterol level is supposed, diabetes also is supposed to be one of the causes as such. Incidence in above 50 years is more common than the other way. Mortality rate also is higher in men than the women. And I would consider this from our point of view as either Valaya, Balasa or Ekavrunda or Vrunda. These are the different categories of these conditions where there would be a significant dysphagia and the patient would not be able to treat it, like asadhya conditions. Balasa eva ayatam unnatam shofam karoti annagatim nimarya. The conditions where the annagati, the swallowing activity is affected. Sarvatheva aprativar viryam vivarjaniyam mudayam mudanti. It's considered as asadhya. Then the other variant of this would be Gadet Shofam, Kurutak Pravudho, Shleshmanilo, Shwasar Lopavannam, Marmachidam, Dustara, Ether Ahu, Balasa Sanyam, Nipunaha Vikaram. Balasa is another of the condition where there could be Marmacheda, that's extensive complications beyond the esophagus could occur, or a visible swelling seen would be in the Ekavrunda and Vrunda. Vrittannato Yashvetuhu Sadaha, Kandanmido, Apaki, Amruduhu, Gurushta. नामना एक परिकीर्तितो व्याधि बलासक्षसे प्रसूतः एकफरक्तज व्याधि और संबंध वृत्तम अमंददाह ये circular swelling seen there is the brunda and it's also the same conditions. Now typically the carcinoma or malignancy seen could be either at the proximal end of the esophagus or the middle area of the esophagus or lower end of the esophagus. Usually the proximal tumors which are seen under the esophagoscopy as surface erosions are squamous epithelium, whereas the lower end is usually the adenocarcinoma. And these adenocarcinoma would have more relationship with the esophagitis or the other quality of the food. The proximal usually is related to again smoking and the quality of the food as such. Alcohol consumption also increases the chance of the proximal pathology. Clinical symptoms are, and of course, the variants, as we see at the esophageal scope, the presentation of the tumors could be of different sorts. Either it could be small polyp-like or a huge ulcerative condition, or there could be even severe erosion as such. That's the typical features. The area of the tumor pathology can be presented in terms of mucosal changes. Early changes can occur, and these could be seen in different shapes as such. And this extent of these areas of the erosion also can predict the prognosis as such. Along with that, many of the esophageal tumors also may have a dermal keratosis, thickening of the skin in the palmar or the plantar area, which also could be a sign, maybe a coexisting symptoms in case of the carcinoma of the esophagus. So that's the important issue. The esophageal cancer is graded based upon the extent of the lesion in terms of the depth. When it is limited to the mucosa, it is called T1. When it is extending into the submucosal area, T2. Beyond the submucosal area, it is T3. And the prognosis, 5-year survival period, is also based upon these degrees. If there is advanced degree, 5-year survival period is 0, whereas early stages it could be 80% of the patients can survive. This is about the outcome of the current protocol of the treatment. The current protocol of the treatment of esophageal cancer is interventional as well as the chemotherapy and radiation as such. That's about, in brief about that. From the clinical point of view, our experience point of view, esophageal cancer is quite difficult to be treated with any Ayurvedic protocol of the treatment, because the patient would have a swallowing difficulty and all our medicines have to be given orally. So any patient of esophageal cancer, I would be referring the patient to the contemporary oncologist therapy, and outcome is relatively poor. The whole course of the treatment also is quite extensive and quite destructive. Uh, and that's about the esophageal cancer in brief. Next part we will take up the disease of the stomach in the next session. So if there are any questions, we will try to answer and then wind up today. There is some question. What is the significance of anatomical esophageal constriction? Is it construction or constriction? Why alcoholic people suffer esophageal varices? The esophageal varices is something different. Of course, I have not referred to that esophageal varices. That's due to the liver pathology. A consequence of the liver pathology can present with the dilatation of the esophagus, esophageal vessels, and hence the varices can occur. It's a vascular pathology where the blood flow in the veins of the esophagus will be increased. So that's it. Then anatomical esophageal constriction, I think there is nothing special about it. Occasionally it can result in a congenital variations in the formation of the esophagus, that there could be constriction. And that part again, congenital pathologies we have not really discussed. Varices, of course, I have not just included in that our discussion. Maybe we can discuss about that issue in detail in due course of time. Particularly, it's related to the hepatic system. So we will discuss that during the discussion of the hepatic disorders in due course of time. Right? Okay. So we'll conclude.